Now we're going to talk about specific diseases. We're going to start with defects of antibody production, or the B-cell defects. And a classic one is going to be Bruton's A-gamma globulinemia. This is an X-linked disease. It's important to know that because that means it's going to be present only in boys. So when you're reading the test question, look for males in the family. So they might say that this child is a male, and they might talk about uncles or brothers having similar signs and symptoms or similar disease, and that's throwing you down the path of only males are affected. That takes you towards a Bruton's. Typically, these patients don't start to have infections till the second 6 months of life. For the first 6 months, they're protected from passive maternal antibodies. So start looking for the age at which they start having infections. These patients are at high risk for pyogenic infections, also infections with enterovirus and hepatitis. So look for enterovirus and pyogenic infections and start thinking of Bruton's, especially if they talk about boys. One thing to remember on the physical exam, and this is going to be different from another disease that's only in boys, but we're going to talk about, in this case, lymphoid hypoplasia. So you're not going to really be palpating the spleen or enlarged lymph nodes with Bruton's. Remember that. Very important thing to know. When you order the immunoglobulins, they're going to be decreased across the board. It's an entire hypo or A-gamma globulinemia, and so all of the immunoglobulins will be low. The definitive test, however, that sounds like a test question, is flow cytometry, and that will show an absence of circulating B cells. There's your diagnosis. These patients will need monthly treatment with immune globulin, which makes it kind of difficult when you're giving live virus vaccine. So now we can go back to the vaccine chapter, and remember, if you give immune globulin, you have to wait 3 months before you give live vaccine. Another one is the common variable immune deficiency. It's an acquired disease later in age, and it's going to be in both sexes. So they will describe girls having the disease. The B cells actually look normal, but they don't differentiate into the immunoglobulin providing cells, and so the infections will be similar to Bruton's. So again, they'll have recurrent pneumonias and chronic sinusitis, things like that, but rarely will you see enteroviral disease associated with the pyogenic diseases. Again, on exam, to differentiate this from Bruton's further, so you know Bruton's is only boys. Bruton's, they have lymphoid hypoplasia. In this particular case, it can be boys or girls, and in this particular case, no enterovirus, and in this particular case, also look for normal lymphoid tissue. Complications can include lymphoma, particularly in women. The IgA deficiency, that is the most common of the B-cell defects. IgA deficiency results in an absence of any of the serum or secretory IgA, and these patients are at high risk for respiratory infections. They get chronic upper respiratory infections, chronic sinusitis. They can also have gastrointestinal infections. They can also have urinary tract infections. Complications include a high incidence of autoimmune diseases like lupus and juvenile rheumatoid arthritis, and also they're at higher risk for malignancies. One thing to remember for IgA, the diagnosis will be made on getting IgA levels, but you have to be very careful with administering blood products. These patients have a high risk of producing anti-IgA antibodies, and they can have a reaction to blood products. So if they need a blood product for whatever reason, you need to tell the lab this patient has IgA deficiency so they can do further screening. The IgG subclass deficiencies, this is why you have to, when you order immunoglobulins, you have to order all the subclasses, because you can have one or more of the subclasses that are decreased, although your total circulating immunoglobulin may be normal. Most IgG 2 deficiencies will be associated with an IgA deficiency, and later on they'll develop a general immune dysfunction. Typically you don't need to treat them with immune globulin unless they have deficiencies to a wide range of antigens, and then they would need supplementation. We're now going to discuss the T-cell defects, and the classic one is DeGeorge syndrome. This is a problem with the pharyngeal pouches. It will cause a thymic hypoplasia, and that's what's going to cause your immune deficiency. However, the parathyroids are also going to be affected, and that's going to cause hypocalcemia. Hypocalcemic seizures are the most common initial manifestation of DeGeorge syndrome. So you'll be reading a test question, and they'll describe a baby that's in the newborn nursery who has now had a seizure. And remember, we said at the very beginning, at the first chapter, we talked about part of the workup for seizures in the newborn. You're going to get a blood sugar. They're going to report a normal blood sugar. But you're also going to get calcium. And on the exam question, it's going to say that the calcium is low. They will probably then go on to describe some of the typical findings of DeGeorge syndrome, and that's how you're going to make your diagnosis. So look for an infant with a hypocalcemic seizure before you think of anything else. They will have heart defects, and the most common one will be a truncus arteriosus, and that's very common with DeGeorge syndrome. And they can have other congenital heart disease, ASD, PDA, but think of truncus arteriosus. They have dysmorphic facial features. Typically, they have a small chin, so they have micrognathia. They have what's described as a fish mouth. It's a very round mouth. They will have low-set ears, and they'll have wide-spaced eyes. It's also known as hypertelorism, and this is DeGeorge syndrome. Other findings include a bifid uvula and possibly esophageal atresia. Here's a child with DeGeorge syndrome. You really can't see the low-set ears here, but you can see the wide-spaced eyes, okay, and a kind of a tinier chin and jaw. Down here on the bottom, this is the normal anatomy, and you'll see that the aortic arch comes up, and there's the descending aorta. However, in this particular patient, they have an interrupted aortic arch, and actually, if you look at the drawing, it's more of a conotruncal defect. They'll have a common outflow tract. So this is an interrupted aortic arch. You see that the arch is coming up this way, then it's somewhat interrupted right here where that asterisk is. And on the angio, you can see a large vessel exiting the heart. This would be your conotruncal or your truncus arteriosus. Again, look for a neonatal hypocalcemic seizure. These patients, since they have a T-cell defect, will be more susceptible to viral infections. So they won't have the bacterial infections that you'll see with like Bruton's or the previously described immune deficiencies. These are more susceptible to viral infections. They are also at very high risk for graft versus host disease. So we talked about IgA, we talked about anti-IgA antibodies with blood. With these patients, you have to be very careful with transfusions because they can actually have a graft versus host disease, particularly non-irradiated blood. On exam, they'll have very little thymic tissue. Most patients have a little bit of thymic tissue and not complete aplasia, but they can have a spectrum of amounts of thymic tissue. But they will have normal lymphoid tissue and the characteristic facies that we described. With DeGeorge syndrome, some of the labs that you'll see are a decreased absolute lymphocyte count. They also have a decreased CD3 count. And if you go ahead and do the respiratory burst, it's absent. The treatment for DeGeorge syndrome is, first of all, if they have a heart defect, you need to take care of that. But typically the long-term treatment is going to be tissue transplant of thymus or a bone marrow transplant. And that would be the definitive treatment for DeGeorge syndrome. We have some combined antibody and cellular defects. The first one is severe combined immunodeficiency. This is an absence of all immune function and plus minus natural killer cell function. The most common form of SCID is going to be X-linked, so again, look for boys. There's also an autosomal recessive form, which is more common in Europe. These babies will have an earlier presentation than other children with immune deficiencies. They can have diarrhea, pneumonias, otitis media. Now, some of these things are things that you'll see in a normal child, but when you see the recurrence of it, and a child can have an otitis media, a child can have diarrhea, but when you start seeing chronicity, that's when you start getting suspicious. They will have failure to thrive because they're always ill, and they are also at risk for opportunistic and viral infections. They can even have a graft versus host reaction from circulating maternal T cells transplacentally. They will have lymphopenia from birth. And they will have no immunoglobulins, and they will have no antibody responses to a mitogen, to a challenge, and they'll have no mitogen response either. These are pediatric emergencies. These babies will die from overwhelming infections if you don't do something about them, and the definitive treatment will be a bone marrow transplantation. Obviously, the earlier you transplant them, the easier it'll be to take, and the better the prognosis. Recently, gene therapy is also being tried. Wiskott-Aldrich, this is a common one to get asked on the exam. These babies will have low T-cell function, not completely absent T-cell function, but it will be low. It is also X-linked recessive, just like Bruton's, so you're going to see this only in boys. These babies will have characteristic findings such as eczema. They also tend to have thrombocytopenia. The thrombocytopenia leads to petechia, so that's two skin manifestations, eczema and petechia. It's a combined immunodeficiency, so they will have recurrent infections. Look for draining ears. They will mention that in the text of the question. That's a kind of a giveaway for these children. These children, as opposed to Bruton's, will have palpable lymph tissue. So you might get a question about a child who has persistent bleeding 1 or 2 days after having a lymph node removed. Well, right there they're telling, why was the lymph node removed? If they have lymph nodes, forget about the Bruton's and start thinking about something else. Then they start talking about the patient still oozing, has a low white count. They might talk about uncles who have had recurrent pneumonias or died from overwhelming infections. You need to start thinking about Wiskott-Aldrich. This is a mnemonic for Wiskott-Aldrich, Mr. Text. The M stands for low IgM. The R stands for recurrent infections. The first T is for T cell defect, even though it's a T and B cell. The E stands for eczema, the X is for X-linked, and the last T stands for thrombocytopenia. So that's a quick way of remembering some of the characteristics of Wiskott-Aldrich. The labs will show an elevated IgA and also an elevated IgE, but again the IgM is low, and you'll see thrombocytopenia. You can do some genetic testing for carriers of Wiskott-Aldrich. These children will get recurrent infections. They can die from overwhelming infection, and they will need bone marrow transplantation as their ultimate cure. They are also at higher risk for malignancy, and they can bleed from the thrombocytopenia. Ataxia telangiectasia, pretty self-explanatory term. Too bad not all diseases are named that way. It's on chromosome 11, and it's a humoral and cellular deficiency. These patients, one of the first neurologic findings will be a cerebellar ataxia. So look for patients that are having a strange walk or they're starting to fall and get clumsy. And usually by the time they're 12 years of age, they will be wheelchair bound. Also, since they have an immune deficiency, look for recurrent infections such as sinusitis and pneumonias. Usually they can also have viral diseases, and they tend to do okay from their infections. And typically they will have telangiectasias. These will be present anywhere on the body, but they're very common on the bulbar conjunctiva, and that's a real easy place to see them. Another clue would be what we call mask-like facies. They can also develop drooling and special tics. So here's a patient with ataxia telangiectasia, and these are the telangiectasia on the bulbar conjunctiva, also some on this side. They'll have an IgA deficiency and also a decreased CD3 count and also decreased CD4. And these patients are at higher risk for malignancies and adenocarcinomas.